This is EHJ Today at the annual scientific sessions of the American Heart Association in Chicago in 2014. I'm Tom Lucier, Editor-in-Chief of the European Heart Journal, and I'm talking to Laura Morey from the Brigham and Women's Hospital and Harvard Medical School in Boston. Welcome.
Thank you, Tom. My pleasure.
So we're discussing the DAPT trial, and tell us a little bit about the background of your work.
Sure. Well, the DAPT study was begun really in the context of trying to understand what patients who receive coronary stents should be treated with and for how long. And you remember back in 2006 there were concerns about the safety of drug-eluting stents. And although at that time we were reassured by some further analyses that drug-eluting stents were safe, we still didn't understand how to prevent that rare occurrence of very late stent thrombosis after 1 year. And the US FDA requested that the various companies who manufacture these stents design a trial that would be appropriately sized to answer that question.
So the stent thrombosis obviously now has an incidence around 1%. So how many patients did you calculate from your power analysis would be required to address the issue?
Yeah, you're right. Stent thrombosis is such a rare event, but an important one. So we required almost 10,000 patients to be able to have a sample size enough to be able to look at not just stent thrombosis, but also prevention of other hard clinical endpoints. So we actually designed it with both the stent thrombosis endpoint and the clinical endpoint of death, MI, and stroke.
This was a combined endpoint of everything?
Yes, it was.
Mm-hmm. And what was the design of the trial overall?
So overall, we enrolled 26,000 patients.
Mm-hmm.
Some of those patients were treated with drug-eluting and other with bare metal stents.
And it was at the discretion of the operator?
Yes, that's right. That was at the discretion of the operator. And the type of drug-eluting stent was also at the discretion of the operator. And we actually enrolled 4 different kinds of drug-eluting stents, but the vast majority of them were everolimus-eluting stents, just like we use in very common practice today. And the drugs that were used were aspirin plus clopidogrel or aspirin plus prasugrel. Patients were followed for the first 12 months. And then if they were eligible, they were randomized. And I say if they were eligible because if they had a heart attack in that first year, then dual antiplatelet therapy would have been obligatory and they couldn't be randomized.
Sure.
Or if they had bled, then they would not be able to take dual antiplatelet therapy, and they were not. We randomized patients 1-to-1 to either continue the thienopyridine plus aspirin or receive aspirin alone.
For how long?
For 18 additional months, so to a total of 30 months.
Right. And there was no stratification of prasugrel and clopidogrel? This was also at the discretion of the operator, or?
Yes, the choice of drug was at the discretion of the operator. There was stratification for the analysis just to make sure it was balanced. But you can't make a direct comparison because they may be different populations.
So what did you find?
Yeah, so what we found within the drug-eluting stent treated patients was that there was a significant reduction in both stent thrombosis and the major adverse cardiac and cerebrovascular events. So for stent thrombosis, there was a 71.
If you continued then?
If you continued, yeah, if you continued, correct. 71% risk reduction for stent thrombosis, and for the composite endpoint, there was a 29% risk reduction. So really, actually much more profound reductions than we had planned for our sample size. If we had stopped this trial only 3 months after randomization with the same sample size, it would have been positive.
That's amazing. And what about bleeding? This is of course also a major concern. Otherwise we would all continue without any doubt.
Yeah, that's the whole reason to do a trial like this, because we knew that there was a bleeding risk, but we didn't know if there was a benefit. And I only say that because the trials preceding have been smaller and they haven't been powered to look at stent thrombosis. And for bleeding, there was an increase. It was in line with what we expected going into the trial. We expected, about a 70% relative increase, and what we saw was a 61% relative increase in bleeding. The endpoint that we looked at was moderate plus severe gusto bleeding, but most of that bleeding was moderate, Not to say that it wasn't important, but it was not severe, and only 1 out of 1,000 cases were fatal, and that was true in both arms, that only 1 out of 1,000 cases were similar for fatal bleeding.
How did you assess the bleeding? Was it the BARC criteria or TIMI, or what was it?
We adjudicated both gusto, moderate and severe bleeding, and also the BARC criteria. So if you look at more sensitive measures like BARC type 2 bleeding, any actionable bleeding, much more inclusive, there's a significant difference there as well.
And what happened in the bare metal stent group?
The bare metal stent group is very interesting. It will be presented by my colleague, Dean Kariakis. And we looked at 2 things in the bare metal stent group. One was comparing drug-eluting stents to bare metal stents. And this was 10,000 patients in a propensity-matched analysis.
10,000 bare metal, 10,000? It
was about 8,000 drug-eluting to 2,000 bare metal, approximately. Because the enrollment, as you can expect, the GES is much more prevalent.
Sure.
But it was very well powered and very strictly adjusted. And we found that we had designed it to see if drug-eluting stents were as safe as bare metal stents, but we actually found that they were safer in terms of stent thrombosis. So within the first year already, there was a reduction in stent thrombosis risk and a reduction in the composite of major adverse cardiovascular events as well. And I think this goes along with the newer data that we're seeing.
Absolutely. What was the relative risk reduction roughly?
It was, approximately 1 percentage point.
Absolute.
Yeah, absolute. Yeah.
All right.
Yeah.
Very good. Yeah. Good. And what happened in the drug-eluting versus DS after 1 year?
After 1 year, there was pretty much flat curves, which is interesting. So most of the risk seems to be, the difference in risk seems to be upfront.
Right.
After that, they seem to behave the same. But we also, just to mention, we randomized bare metal stent treated patients as well. And although the group is smaller than the drug-eluting stent group, the reason we did that was to see were the findings consistent, because obviously many of us are using bare metal stents thinking that maybe we can use a shorter duration of therapy for bare metal stent treated patients, and perhaps that would be safer for our high-risk patients. However, what we found was that the magnitude of stent thrombosis risk reduction was the same.
Exactly.
Yeah, and it is on par with what we saw within the drug-eluting stents, which is that even across all the different stents, the older and the newer stents, the relative risk reductions were the same. We know the absolute risks may be different from the trials, but the relative risk reductions are the same.
So we also did some interviews with other trials, and we were also discussing the Mili trial. That was there usually were 2,000 and a bit more patients, so much smaller. So do you think it's the difference between their results and your results are mainly driven by power?
Yeah, I think that the results are actually entirely consistent in that if you have a smaller trial, you won't necessarily be able to detect a benefit. But you can detect bleeding because that's a more common event.
Exactly.
So it's not surprising. I think it's not that it's one study is right and one study is wrong. They're consistent. And I think the fact that there have been so many studies done is just an indication that we want to know this answer for our patients. I think if I had to put my finger on the biggest surprise from the DAPT study, it's really how profound the risk reduction is outside the stent. We started this trial with a stent-related question, but I think it's really become a question of secondary prevention, because the majority of the myocardial infarction that we prevent, because we cut the MI risk in half with the continued thienobutidine therapy, the majority of those events are outside of the stent. So then it really becomes the stent is just a marker for atherosclerosis, and giving continued thienobutidine therapy reduces our patients' risk for events in the future.
So what's the take-home message for you?
I think the take-home is if our patients can tolerate a year of dual antiplatelet therapy, that there is a benefit to them continuing beyond that point.
So would you assess in your private practice the bleeding risk of a patient before reaching such a decision?
Absolutely. You know, the way that we assessed it in the trial is that we excluded any patient with a history of major bleeding.
Right.
And I would say that probably the operators also excluded patients that they thought were very likely to have a serious bleed. But beyond that, the trial was very inclusive. it's important to know we didn't include patients who got warfarin or other anticoagulants.
Yes. That's another question as well.
Yeah.
Well, thank you very much. This is very enlightening.
Thank you. It's my pleasure.